All right. Thanks so much, everyone, coming to Rounds at an unusual time. So I'm really impressed with the turnout, and I hear there are a lot of people online in the webinar. So let's get started. It's a great pleasure today to introduce Dr. Wanrudee Isaranuwatchai, who is a friend and a colleague. So it's especially nice to have you here today. So she's a scientist at the Shing Institute at St. Mary's Hospital, where she's also the director of the Center for Excellence in Economic Analysis Research called CLEAR. So everything is clear after that. He's right. And she's also assistant professor at IHPME at the University of Toronto. But so right now, this year, or this academic year, she's on a secondment kind of thing. So she's a senior researcher at THETA, which is Health Intervention and Technology Assessment Program in Thailand. And so I'm really excited for her to be here and tell us about everything about HTA in Thailand or in Southeast Asia more general. That's it? Yeah? Okay.
Maybe not everything.
Maybe not everything, but enough for all of us to be clear on what's going on in HTA in Thailand. So,
and maybe one Thai food afterwards.
Okay, great. All right, so before we get started, same as at each THETA round, we're going to introduce ourselves. Also, I think Wanrudee knows most of you already. So I'm THETA Sander. I'm a scientist here at THETA and also associate professor at IHPME. And then let's go around.
Yes. Hi, I'm Ashra, and I'm the health economist at CLEAR, working for Wanrudee.
Hi, I'm Haley. I'm also a health economist at CLEAR.
Hi, I'm Dina. I'm a research assistant at CLEAR.
Rick Cron. I'm a director of THETA. I'm George Tomlinson. I'm biostatistician here at UHN.
Joanna Bileski. I'm a research librarian here at THETA. I'm also online moderator today for, we have 5 people online.
I'm Marina Richardson, PhD student with IHPME. I'm Eva, research associate at THETA.
I'm Desmond Moon. I'm a health economist at CLEAR.
So now I'm a PhD student at IHPME.
Andrew Reynolds, a PhD student at IHPME.
Max, PhD student at IHPME.
Juan Pablo, PhD student at IHPME.
We get boring, guys.
Rafael Jimenez, postdoctoral at THETA. Rafael, research associate at THETA.
I'm a GI fellow at the kids, but I'm working with Marie.
Alex Haynes, health economist at THETA.
Troy, research associate at THETA.
Neil Kirkwani, research associate at THETA.
Today.
THETA and HPME.
Yes.
Okay, so thanks so much. Do you want to take questions in between or at the end, or?
Either is fine. Yeah.
Either is fine.
Yeah. So if you really cannot hold your question, feel free to throw them. And really, I'll start by saying thank you for having me here. And there's also, I think it's a great holiday lunch afterwards. So we'll stay tuned for that. So Saturday, June 23rd, 2018. What were you doing? I think it was it's still summer. It's my birthday. So lots and lots of celebration. But middle of the summer, you could be going out for brunch with your friends, meeting up with the family, going for a walk, going for hiking, biking trip. Now, if you were going on a hiking trip or biking trip, you were not the only one. On the other side of the world, a group of teenagers, kids, they did the same thing. So they went on a biking trip, and they're part of this youth soccer team. And they took their bike to a cave where they go on a hiking trip. And that was that. Not knowing what's going to happen to them, that will change their life forever. They will change many people's lives forever. And nobody really know about it. But the news really broke 2 days after, when we found out that there was a flash water flood that blocked the entrance of the cave, trapped 12 youth soccer players, including their assistant coach. Now, have anybody heard about the news here? Yeah. Pretty much almost everybody. So where was this cave? It was located in the northern part of Thailand called Shing. And the cave is known as Tham Luang, which is located on Nam Non Peak. And the entrance, as you can see, is right there when they entrance. But the thing is, the entrance is now blocked with water. So at a certain point, there was around 5 meters of water. So even though the rescue and the search started, they couldn't really start because they couldn't find a way in. Dozens and dozens of water pumps were put there in order to just clear path for emergency response team to go in. So, and as you can see, some area, so we know we have to walk in the cave and we know we have to dive. And those shouldn't be that difficult if you think about going for a hike, but it would be if it looked like that. And when you think about diving, for me, at least commercial to Myrtle Beach or Sandal come to mind. They tend to do that, especially in winter. But the diving condition here is not like that. The diving condition here has zero visibility. So in one of the picture instructions, it showed that the diver cannot use fins to start, and they have to use a rope guidance point because they couldn't even see any meter. So the only way to direct them is by using rope. And they're going to start diving. There'll be part where they have to climb. They'll be diving again. And at one point, they actually have to take off their scuba tank in order to get through one area, to get past to the area that they think the soccer team and their coach kind of migrate to escape the water. And after they pass that point, they have to climb 45-degree slope with all their gear just to dive again. So they did this. And it sounds difficult, and it was. But in a way, everybody had hope. It was not just Thailand. Over the week, I have a number of calls with people, teleconference with people in Canada, in other countries, and we start off the conversation by how are the boys doing? Have we found them? And at that point, I said no, but thank you for your thoughts and prayers, and people have hope. And just to have situate how difficult it was. Unfortunately, life was lost, right? Even the former Thai Navy SEAL died during the rescue attempt. So, but people still have hope. But it's been a week after, still no sign and no news. And let's rethink. It's been 1 week after, we're still looking for 13 lives. We know for sure in the cave it's pitch black. The water keep going up and the pump keep breaking. The pumps are brought forward. And the rule of three for survival. Does anybody know the rule of three? No? So human beings supposed to be able to survive 3 minutes without air, 3 days without water, and 3 weeks without food. So that word was repeated. So yes, time is running out. So new idea approach. So while people attempt to work through the cave area, people also thinking, why don't we dig from the top? Just like back in 2010, when 33 miners were rescued, right? Why don't we dig from the top? But now, from the map, we have to dig 1 kilometer through hard rock of mountains. But they did start, because anything that they can do, right? But after many attempts, support from people from around the world through different level, emergency response team, different level of soldiers and SEAL team, we actually did. We got a good news right after Canada Day on July 2nd at around 10:30 that all 13 lives were found by 2 British divers who become very, very famous right now. So finding them, that's the first task. Everybody was happy, but that's not it. Additional collaboration needs to happen in order to get everybody out. There was no other way out. And the way in was difficult. The way out still going to be difficult, but even more difficult because we're talking about 12 youth and all 13 of them have no idea how to dive. So long story short, they did it, make it happen. But it was a lot of effort, and they were competing against time because the water level keep going up. I don't think they really advised on the news, but right after the last kid was rescued, within no more than 2 hours, the entire entrance was collapsed for a period of time. So we were quite close. And I'm not sure you also heard that Tesla owner, what's his first name? Yeah. So he built this really cool thing, and he actually flew it all the way there, but we didn't use it. And it's not because it was not a good idea. It's because if we were to wait for it, we wouldn't have enough time to get people out. So, but everybody made it back. So this is a picture that the assistant coach took before they went on the trip. And very fortunately, it was not the last picture. We see them again. Now I'm telling you this story because then one way to think about it, I think the Washington Post has summarized it in the headline. Was this a miracle, a sign, or what? How the world came together to save 12 boys trapped in a Thai cave. It was a collaboration across so many different countries, so many different organizations to make this rescue possible and not make it a recovery, but a rescue. The world did come together back in June 2018. I think the question for us now is, could the world come together again to help ensure that every life have access to basic healthcare support? Could we come together to support universal healthcare? And if we think about it, maybe we already have, but can we remain together to make this possible? Here's a map of countries with universal health coverage. Now, we're very fortunate to be in the green area. Canada certainly have access to universal health coverage. But as you can see, more than half of the world do not. So could our collaboration across country come together to ensure that one day, or based on the campaign they're working towards it, by 2030, that every country, every human being will have access to basic healthcare support? And I'll take a step further, because I'm at THETA, and what are the potential roles that HTA could help in this priority setting process? So thank you again for having me here today, and thank you for joining. And to the question of how can HTA help? The answer is there's many ways that HTA can help. I'd like to share with you about some of the work that are happening in Southeast Asia, potential role that HTA has played, and potential role that all of us, no matter where we are, can contribute to the goal toward universal health coverage for everyone. The key take home from the story that I think that stay with me is collaboration. There was collaboration to rescue the soccer team. The team name is Mung Pa, which means wild boar. That's the name of the soccer team. And I think the concept of collaboration kind of echoing throughout in many industries, including when we're thinking about how can we work together to support universal health coverage. So for the remaining of time, I like us to have more like also a discussion as well. So I only prepare a few slides just to share with you a little bit more about the HTA agency that I've been part of over the past months and will be there until summer next year. And I'd like to share a little bit about the work that we are doing, also other initiatives that are happening in Southeast Asia with the goal to help to apply HTA to help toward the goal of universal health coverage. Now, Thailand. How many people have been to Thailand? Oh, really? Okay, we got to change that. Really got to change that. So people on the line, not many people are putting their hand up. I hope some of you put your hand up. But okay, I think next holiday lunch could be in Thailand. We get our directors who say yes, so that's a good sign. So anybody want to guess what's the population in Thailand? How many people? So in Canada, how many we have?
35.
35, yeah, 35 million. So in Thailand?
60 million?
60?
60, yeah.
Yeah, that's pretty close. So it's almost double of what the population in Canada. Health expenditure is around 5% of GDP. Life expectancy though is quite a bit lower. That's the rate for under 5 mortality rate, maternal mortality rate, and the establishment of the universal health coverage started in 2002. Now, even though Thailand has population double the size of Canada, Canada is 19 times bigger in size, geographical area than Thailand. Now, that matters because as I'll come back to this shortly, but geographical location, especially when you think about low and middle income countries, that affects delivery of care. It affects delivery of care in Canada. So in those low and middle income countries, it affects significantly. So all these play a big part when people are planning on how to implement universal health coverage or how to do HTA. So here's a color time map overview of the HTA development in Thailand. The first economic evaluation, it was published in Thai at the National Journal. It was published back in 1982, actually. Now, over that time, there was, we call it economic boom because there was a lot of investment. Many countries are doing well. The economy is getting better. So WHO also started the Center for Health Economics at one of the universities there. But then, 1997, that's when the Asian financial crisis started. Now, does anyone know what Tom Yum Goong is? No? Nobody likes Thai food at all here? Yeah?
Oh, wow.
Tom Yum Goong, right? It's a soup. It's a Thai soup, spicy Thai soup. It's called Tom Yum Goong. I have no idea why, but that crisis has a nickname, and it's known as Tom Yum Goong crisis. Again, I'm not sure why I was searching Wikipedia and I'm like, oh, you got a nickname. That's kind of cool. But Tom Yum Goong is a famous spicy soup. Goong means shrimp. So don't get Tom Yum Goong if you're allergic to shellfish like me. So get something else. But economic crisis happened. So what happened? It's a big reminder to the government to focus on cost containment, focus on the need of evidence for every single decision they were going to make. That led to the establishment of a program called International Health Policy Program, which THETA, the HTA group, is a sister or partner with that group. That group started in 1998, and they focus on the wide range of health policy research, health financing, health human resources. It's a big organization. And they look at many different topics, including burden to health public sector, including how to improve the efficiency of the system. So then, 2002, that's when universal health coverage started in Thailand. And after that, it was the recovery of the economy, and THETA started in around 2006, 2007. I would like to share with you one more picture. Focusing towards, if you're looking at the screen, it would be towards the bottom right, where universal health coverage started in 2002. I'd like to share with you this picture because I attended a seminar about 1 month after I started my sabbatical secondment there. And this picture was shown as a reminder that universal health coverage is not something that we can just make it happen. Things have to be put in place. You can see that looking at the green arrows, those are attempts for the country to move the country toward universal health coverage. We started with having something called low income card scheme that did not work out well, but it took a while to change it to voluntary health card. And in between, we now have 2 more insurance schemes called civil servant medical benefit scheme and social security scheme. So those still here. So when we think about a public healthcare system in Thailand, we actually a 2-tier system. So the private and public. So I'm focusing only on the public. And we think about the public system, it's made up of 3 health insurance schemes. The civil servant one, the social security, and universal health coverage. Okay. Now, in setting this up, those are internal policies. But another key aspect to make USC possible is the infrastructure. Back in the 1970s, there was a mandatory policy that every single doctor who graduates will have to spend a certain number of years in the rural area. Then in the 1970s, 1980s, there was scaling up of district hospitals. So if you think about it, if you want to provide universal health coverage, so sure you have a list of things you want to make happen. But if the population, the patient have to travel 400 kilometers to get access, it's still not accessible, even though it's covered. So in order to plan for universal health coverage, about at least 10 years before USC, a lot of hospitals and a lot of in the province and in district was under budget freeze because the government was redirecting all additional resources to ensure that every single sub-district in the country has a community public health center. So in Thailand, we have 76 provinces, around 800 districts, and around 7,000 sub-districts. So every single sub-district has a public health center. And now all these public health centers, most of them don't have doctors, but at least they have a nurse, right? But those were put in place right before universal health coverage was made available to ensure that the delivery of care are ready when we start offering that. So that's for USC. Coming back to HITAP, so we are semi-autonomous, non-profit research institute. We have a part that is right under Ministry of Public Health in Thailand, but the other section, we also operate as a research institute where we work with both researchers inside the country, outside the ministry, and also work with other countries or external funders as well. And what we do is really we appraise a wide range of intervention and technologies, and we also receive funding from both domestic and international funders as well. The vision is really to ensure appropriate health intervention and technology are made available for the society. We do that by appraising the intervention and technology, develop system and mechanism to manage them well and distribute the findings. Now, in order to support the development of HTA, HITAP have 5 key strategies. The first one, focus on the fundamental system, is really in the development of guidelines. Now, this is something that, yes, Canada, we have it a long time ago. But this is one of the first key steps that many countries in Southeast Asia are looking right now, is to develop both not just methodological guidelines, but process guidelines. Well, how do we go about select what topic to do the analysis on? Thailand follow more like the system in UK, where we actually are the ones who conduct the analysis and not ask the submitter to submit the analysis. And having guidelines, that play a really important part because there was a study that looking at on the first column, you see those are the recommendations of things we should do, as we all know. But before the guidelines, those were not reported. But after the guidelines, we do see those numbers significantly improve because we now have a guideline for people to follow. Now, after the fundamental system, the second strategy focus on capacity building. So every year, HITAP also provide a 1-week-long training in how to conduct economic evaluation using Excel model, and they also focus on how to collect data for economic analysis as well. Then there's a research part in the middle, and knowledge management is the crucial part. We have a separate communication department at the agency where they focus on how to get the information out. There's a number of YouTube available that look at, one of them focus on the introduction to STA using little cartoons, cute, and HTA Shing, I like to come back to that. That's also another network that they create. And last but not least, one of the strategies also focus on network. So we do collaborate with Mahidol University, other university in Thailand, including the group based at Mahidol, which is a collaboration between Mahidol and Oxford University, so called Maru. And these are the national partners. But we are also working with different international partners as well. One of our core partners is known as IDSI, or International Decision Support Initiative, based at the Center for Global Development in London, UK. We work with the WHO, UNICEF, the Access and Delivery Partnership, which is part of the United Nations Development Program, or UNDP. And we also work quite a bit with PMAP, and I'd like to come back talk to you a little more about PMAP as well. Okay, so theory of change. That's one thing that when you are thinking about the entire continuum of HTA and how to institutionalize HTA, theory of change was one of the things that we refer back to, that we need to look at not just one part, but look at the evidence, look at the process, look at the decision in order to ensure that better health can be accomplished. Now, when we talk about evidence, it is about how we create the evidence. That's why the importance of guidelines. Process is being transparent about how decisions are made. Decision is a lot of time we need support from the political side as well in order to help us get to the overall goal. So I'm now going to shift and give you some more specific examples, which I'm certain you'll see the overlap of how HTA are being used in Thailand. But before I continue, I'm going to pause to see if anybody have any question about Thailand or Thai food. So far so good? Okay, all right. Okay, so as you can see here, we use economic evidence to help with making decisions on whether what drug should be included. But in addition to that, it's not just drugs, it's also just general health benefit package. What are type of health services that should be included? We also use it to conduct different type of interventions. So pharmaceutical, non-pharmaceutical, and then also public policy evaluation as well. Focus a little bit about the benefit package and the essential medicine. The economic evidence, this is very similar to what we've seen here as well. We look at cost effectiveness analysis, value for money, budget impact, and they also separate the feasibility to look more at implementation piece as well. But all those then are considered as a economic evidence package that are passed on to be reviewed first by a health economic working group. So we do collaborate with different set of stakeholders, HTA, researchers, health professionals, but all the information then go to health economic working group. Once that's approved at that stage, then it then pass to the subcommittee. We have one on your left-hand side that look at the benefit package. On your right-hand side that look at the national list of essential medicine. All medication, once come through or introduced, they considered as non-essential. In order to be considered essential medicine, you have to go through this process. This is interesting because for other countries such as Vietnam, they didn't do it that way. In Vietnam, all medications are already started out as essential medicine. So when we look at their list of medicine that they cover, the list is a lot longer. So then after the subcommittee have the decision, it finally gets approved by the chair from each group, National Drug Committee and the National Health Security Office Board. Okay, so just to kind of highlight some of the process or step we took for each type of economic evaluation that we are all doing. And again, you'll see that there's significant overlap with the process that we do here as well. All projects start with having a stakeholder meeting. Then that proposal needs to be presented to the health economic working group before they can continue. Once approved, then the researcher can then start doing the work. once they finish the preliminary finding, it has to be presented to the stakeholder at the stakeholder meeting, be reviewed by both internal and external reviewers, then finally be presented and approved by Health Economic Working Group before that work then presented to the subcommittee. I think that's a question. Will they say something?
Attention, please. The Butch family, could you please return to MSICU? The Butch family, please return to MSICU.
Is there a Bush family in this room?
Can I ask a question?
Yes.
So at the top of the slide, it says HTA studies.
Yes.
And then it says HTA process guidelines.
Yes.
But all I see is economics.
Yes.
Is economics and HTA perceived to be the same thing?
Oh, that's a really great question. It is, but that's one thing I learned as well, that for them, the process is, so short answer is no. So economics is only one part of HTA. Yes. So then also, I didn't really focus more on the clinical evidence. There are also ethical considerations that need to be considered before we get to this point. So before study make it to this point, they have to be shown that it's actually clinically effective or meaningful to look at, that ethical considerations are being made. And there's a lot of subcommittees, like a lot of subcommittees. That's why I'm focusing only on the subcommittee you're seeing here, because the list, there's a lot of subcommittees who focus on other aspects as well. Yeah.
So it's a stepwise progression, or it's happening in parallel, or you have like, you get your stamp for each step and say,
Yeah.
you know, effective, yes, ethics, okay, economics.
Right. That's really great question. So in general, it's more like a stepwise, but I think there are special cases where when things are very, very important, so it even got some steps got skipped to come directly, but nobody ever skipped, from what I understand, in the economic piece. Again, because budgets are very limited. So sometimes certain clinical or, like, you know, if there's strong evidence already to support the intervention, then it didn't stay with the subcommittee too long before it come to the Health Economic Working Group. Yeah.
So how long does it usually take the whole process?
For the whole process, I'm not as sure yet, but for this whole process, usually within 6 months. Yeah, which is very quick. Yeah, yeah. And I have a opportunity for this year, and I attend now 2 meetings to actually sit on the Health Economic Working Group. It's been a really interesting experience learning and practicing my Thai. All the documents mainly are in Thai. Well, some presentations are not, but because it's Thai government document, right? So everything are written in Thai.
Yeah, actually, where you're going back to this one, right? What exactly is the difference between the two?
Oh, so this one is only medication. This one is everything else that's fine.
Okay.
But they have a very clear path between the two. And both are, but as you see, there's a common link with the Health Economic Working Group.
So it's the same health economics group, or is
It's separate. Okay. I'm only sitting on the medicine group, but not the other group. And they meet every month.
Who are the stakeholders?
Oh, so patient groups, and a lot of time are clinicians. So there's patient group, there's patient representative. Sometimes it's general public we do post the information so people can apply to come and listen. Yeah. Right. Thank you. All right. Now, as you can see in this slide, Thailand is only one country. We know that. We are quite small too. But one other thing is we situate among many great neighboring countries where we have great collaboration and great network. Now we are one of the country who have many lessons learned, things that we should do and things especially that we shouldn't do that we could share. So the country start getting requests from other countries to come and share experience about how to set up universal health coverage. Concurrently, when we want to get to universal health coverage, HTA is embedded to be a key component on how to help with priority setting. So we get requests for how do we institutionalize HTA, how do we help set up a US universal health coverage. Because the increasing demand, in 2013, HITAP created a group called the HITAP International Unit, where the goal is to help build HTA capacity for other different countries. And one of the key things is really to foster collaboration across organizations and across countries. The way we see it is it's really a two-way street. We learn as much as the group that we're working with learn from us as well, right? So we work now, again, not all of these happened in the past 5 months I was there, just to be clear. But the group has worked in many different countries, as you can see here. So India, the work still happening there. Sri Lanka, I think we finished that work. Indonesia, we wrapping up that work. Philippines, we are still working with them on other projects. Vietnam, we are still working. Nepal, Myanmar, and we also now working with East Timor and also Bhutan. I'm flying back tomorrow, and then next week I'm going to Bhutan. We'll be looking at economic evaluation of rotavirus vaccine for kids in Bhutan. So these are just some of the examples around the type of collaboration that we create with other neighboring countries. But certainly, HITAP, we do have partners who help make this possible. Many of the groups located in United Kingdom, but our main core partner is IdeaScience, which is part of the Center for Global Development. We receive funding from DFID, Bill and Melinda Gates Foundation, and Rockefeller Foundation. And when we collaborate with each country, the approach we've been taking is really the pool model, where it starts with the country request. It was never the case that we are thinking, oh, we want to explore that country, see what happens. It was really through meeting at different global conferences, including World Health Assembly, UN meeting, that the minister from different countries approached the minister in Thailand to say, we're looking to implement HTA program or to start HTA program. Can you connect us with someone from your group? And that's when the request come down to HITAP. And the three main approaches that we use focus on technical capacity building, HTA system development, and health system strengthening support. Now, certainly the group at HITAP, they focus on HTA system development. Technical capacity building specifically for HTA. But as you think about it, health system strengthening support, that involves more than just HTA. And that's why collaboration with other groups, such as the International Health Policy Program in Thailand, who have health economists that with specialization in health policy or health financing, we also collaborate with other groups as well. And a lot of time, we also collaborate with other external groups outside Thailand. So right now, these are all the countries that we have working. We now, as you've seen, getting to work a little bit more in the Africa countries. So in Kenya and Ghana, last month, we have 8 delegates from the Ministry of Health in Kenya came to have a study visit to learn about the system in Thailand, to learn more about HTA, and we're planning another study visit in March, where we'll hold technical workshops talking about economic evaluation in those countries as well. All right, so I want to share with you a couple more examples in terms of the type of project that the group has worked with. So when I arrived HITAP in June, there was a health economist from Philippines. She was there for only a few weeks, but then when she made a presentation, she was working on a project, and she now heading an HTA unit in Philippines. And it started because last year, the Philippine House of Congress finally approved the Universal Health Coverage Bill. It did not just happen. Again, IDSI, HITAB worked with Philippine government for a number of years. Finally, the House of Congress approved it, and this is the key part because they recognize that HTA is the key to achieve universal health coverage. And having a government who come out to actually support this, that yes, in order to have USC, we also need support to create HTA units. I think that actually echoing quite a bit to many other different countries. Because, for example, like Kenya, they are looking at not just how do we get to USC, but how do we set up HTA units in the country to help make USC a reality. The group in Thailand also, in Thailand also work quite a bit with Indonesia. Last month, they published a policy brief comparing insulin analog with human insulin. They also did some work that they presented at the Global Symposium on Health System Research in Liverpool, again in October, looking at real-world analysis of two cancer drugs that they are suggesting to remove. Last but not least, so this is we're starting a new collaboration with Kenya, where this is one example where the Minister of Health in Kenya met the Minister of Health in Thailand as one of the meeting, and they are saying that based on the new administration, this is going to happen. They like to implement universal health coverage by 2022. So then they start creating a group of experts within the country to decide what are the information they need. And now they have that expert group who came to visit who came to have a study within Thailand to think about, okay, what are the different aspects that they need. Now, certainly Thailand is not only one country they're collaborating with. We know they're collaborating with a number of countries in European countries as well. So in order to implement USC, there are a lot of moving pieces, and HTA is one area that people are looking at of how can we set that up to make this goal possible. Okay, so that's how highlight a few of the work, and I'll just finish by mentioning to you a couple more initiatives. You could look at this as going back to the key concept of collaboration. None of this work happens just by one country or by one or two countries. These are truly examples of collaboration across different countries, across different organizations to make it happen. And in addition to thinking of collaboration, you can also think of as opportunities. If there are areas that you're interested to learn more, I'm more than happy to talk to any of you. There's a lot of visiting scholars who go and work on certain projects in low and middle income countries. Some spend a few weeks there, then come back to continue work. Some spend perhaps a block of time there. So within the past 4 months, I met visiting scholars or interns from South Africa, Philippines, UK, US. So it's certainly a diverse group and collaboration. So other initiative is important is because of this saying that we certainly do not want to reinvent the wheel. We want to build on, and the only way to do that is by recognizing what are already available. And that's why one of the key important concepts is the global public good. Something that we can create that can be applied and used by others. Recognizing you need to do some adaptation between, among different contexts. I'd like to share with you a couple of examples. One is the reference case. Now, when you think about CADAS, we have a great guideline, and trust me, I talk about our guideline many times in Thailand. And there's also a reference case. But our reference case is for Canadian setting. But what they've done here is create a reference case for economic evaluation with a key part which is an aid to thought. And there's a section in the conclusion that this is only an aid to thought and not a substitute for it, and should not be followed without regard to context. But for when you think about coming from a low and middle income country, rather than starting from something from scratch, you have this to give you some guide on the item you want to look into, what discounting rate you should use. So we're working with Vietnam right now at the Health Strategy and Policy Institute to create their own methodological guidelines building on from this work. We also have the STA toolkit developed by IDSI, and we are working with Bhutan and other partners to actually apply this in the project we'll be working on. And also there's gearforhealth.com, which is a guide to health economic analysis and research online resource. It's a global platform to help low and middle income countries if they want to do economic evaluation. There's a lot of information. I'd really like to encourage you to go check it out. There's many different ways for you to engage with this as well. First, completely free to register, and there's a lot of helpful information. There's also a section that says ask an expert. Now, I know a lot of us here are experts, so I'm not really asking you to ask an expert, but the ask an expert option is there, so anyone can come and ask questions, and you have experts to reply. But so I think my question for you is, if you like to become an expert on this website, but really do check it out, because you do get questions. I've been on it for 3 months. I already answered 2 questions about costing. People come to say, we need to do costing for these hospital-based services. What do we do? Then I replied, pretty much starting, I need more information. And then they replied. But these are people like frontline staff who are doing the work, and they are implementing it. So again, these are examples of global public good, of something that group is trying to create. There are experts on the list you'll see from various countries, UK, Australia, Thailand, Malaysia. So I hope we can add a few more Canadian experts. All right. Second to last thing I'd like to mention is Asia Link. Some of you may have heard about it. It's a network. And as you see in here, Asia may keep it the way that it's focused in Asia, but there's also a network from UK and for Australia. Hopefully one day we can put some dots on Canada. But it's really a collaboration among STA organizations, policymakers, government officers. Okay, started in 2011. It can operate on an informal and voluntary basis. There's no requirement, zero, for membership fee. Okay, and the goal is really to help create a network where people don't have to duplicate the work. So if, for example, Thailand is already, so the example I showed earlier about Indonesia, Thailand did an economic evaluation comparing between human insulin versus insulin analog. We are going with the human insulin. It's cheaper. It can save a lot of money. So Indonesia, they don't really have to go through the entire process. They do, though, have to adapt the method and the analysis. So that's what they did, right? So it's a way to share information across different countries, a way to also strengthen capacity in HA in the region as well. Every year, there's a meeting. Earlier this year, it was in Thailand. Usually happen around April or May, and there is no registration fee. It's free to attend. You only have to register, but you do have to cover, you pay for your own travel and accommodation. But if you're interested to learn more about HTA research, HTA movement in Asia, this would be the place where you will get to see policymakers, government officers, decision makers, or including HTA researchers as well. Now, with that being said, one condition for this work is we are not open to private sector. That was one of the conditions. So then there's a true discussion around prices that different countries use without having to worry that some people may use information for other means. Okay, so click here for more information. Last but not least, definitely last but not least, there's a conference called Prince Mahidol Award Conference. It's a global platform to discuss any significant or important global health issue. Now, this is an important conference, important event for Thailand, and the one that many of us hold close to our heart because of the name. Principal Hidon, he is known as the father of modern medicine and public health in Thailand. And so I think one of the things that he has set the foundation for this conference, and it set the foundation for many departments, especially in Thailand, including THETA, to build our work. And what he said is that true success is not in the learning, but in its application to the benefit of mankind. Collaboration is key in getting a lot of the work done in low and middle income countries. But building on from that, there are opportunities. You want to apply your specialty, especially in HTA, to the community, the international community who are certainly in need of your expertise. So I hope that something you'll consider. Like I mentioned, I'm happy to answer any question, talk to you more about any part you're interested in. And because at the end of the day, I think together, everyone achieves more. Thank you.
Thanks so much, Wanrudee. I think we're pretty exactly on time, and maybe respecting everyone's time. So I would want to open it up. Joanna, if there are any questions online.
I just asked, there is no question online.
Okay, then it's open to the room because you're all going to be here anyway.
Yes.
So you can still ask Wanrudee.
Yes.
All kind of questions you want.
Anyway.
So give lots of opportunities for individuals to connect. What do you think the opportunities are for a shop like us who would want to cultivate, greater connections with HTA, international HTA groups? Are they the same opportunities that you would have for the individuals that you've described, or is there something specific that we could do to do more of this?
Thank you. I think that's a really great question. And I know that you do have a strategic planning meeting coming up, which I think it would be great. Now, I think one of the first things is, for me, I'm very fortunate to be able to say that I have two homes, not in a bad way, but so both Thailand and Canada. But I also know that a lot of times we do need to show contribution to Canadians, right? So that's one of the important things not to forget. But at the same time, if after doing that, we would like to consider bringing that contribution to the international platform, sure, some of the specific example may be more at individual level. But if you step back, the demand itself from the country level, there are demand for more expertise in HTA. And I think that's where, as an organization, we could contribute. Again, if one of the focus were to be contribution to the international community. So that will need to be a first step. If it's part of the strategic plan, then second, to specific to your question. So I think HTA Asia Link, that's one of the groups. So it's not really a individual, there's not only individual membership, there's institutional membership. And again, at zero cost. So right now, there's a University of Sydney, a number of organizations in UK, WHO, UNICEF, UNDP, they are all considered as members for HTA Asia Link. But and sometimes, they could use HTA Link as a platform to go and presenting. Sometimes I see the university come and talk about their training. We have program here, we have program at ULT. It's a great platform to go talk more about the type of training. If there are potential for international internship program. So at HITEP, that's one, but there could be one between here and between other developing countries as well. I know already we do have interns from other countries here, so that could be a place as well to share more information about those opportunities. Another thing as well is the technical capacity building. So I'm learning a lot, and one of my interests is real world evidence. So there's certainly interest in real world evidence, but there's still a lot of information that we can share They're starting out, but Canada started already. I think there's certainly information we can share. Modeling is also one of the key areas. They work a lot more in a static model, Excel based, because most people are trained from UK or from Scotland. So, but at the same time, I think their additional training can be done for modeling aspect, and many of them I know that both the biostatistics group and the THETA group, you already have those packages available as well. So I think those have listed a couple of things to build on from what you already have, but there are certainly other opportunities.
Thank you very much, Wanrudee. It sounded like lunch is ready, so, and you'll be here for?
I'll be here
for a little longer?
Yes.
Okay,
yes.
Okay. So any more questions? Wanrudee is going to be here. Thanks, everyone.
Thank you very much.
Sure.
Yeah.